Our next presentation is an interim pivotal study effectiveness data of a coin-sized tibial nerve stimulator for urgency urinary incontinence, 24-week results by Dr. Rogers.
So I'm excited to present the six-month data from the eCoin pivotal trial. I'm grateful for Valencia Technologies striving to deliver neuromodulation to the masses, focusing on the UUI indication. This study involved 6 urologists and 9 urogynecologists who knocked out 133 implants in 7 months. The procedure was designed by Subir Sen, a plastic surgeon specifically trained in peripheral nerve and extremity surgery. He placed an emphasis on reproducibility and safety. My one disclosure. So this is a leadless, flat, nickel-sized device consisting of a primary battery. It has a very unique electrical field where the field emanates from the center cathode to an anode outer rim, very different from the leads we normally use. It's implanted in the office or ASC above the ankle in a 20-minute procedure. 2 unique tools are used, a template and blunt dissection tool, which offers consistent coin placement and pocket creation. The therapy is delivered twice weekly. This automatic, low-duty, intermittent stimulation avoids compliance and maintenance issues often seen with sacral neuromodulation, PTNS, and potentially other emerging TI devices. We also might reduce office visits compared to PTNS and Botox. It was a prospective single-arm study. For screening, you had to have a PVR less than 150. Careful attention was put on the leg, excluding symptoms of neuropathy and claudication, and also checking for pedipulses and pitting edema. Washouts were applied. These are patients who had failed prior OAB therapies, excluding sacral neuromodulation. They had UI daily, and they could not have predominant stress incontinence. For exclusion, they couldn't have bladder pain, neurogenic bladders, and as described, exclusion of leg conditions that would have poor risk of wound healing. It is a simple and fast procedure. It eliminates the need for C-arm or ultrasound with no intra-op testing. It's a modest and intimate experience with a short learning curve and efficient workflow in my experience. The placement of the coin is much more specific compared to placement of an IPG in the buttocks for sacral neuromodulation. Here is a video of the procedure. The foot is placed at 90 degrees. The medial malleolus center part is marked. The template is placed parallel to the Achilles tendon. Local is infiltrated. None of the patients need any general anesthetic. Patients do not receive narcotics or IV antibiotics. The prep is performed. Hopefully we'll have Mayo kits that are dropped on the tray so everything is fast and easy like a central line placement. The toes are prepped out. An incision is made. This is placed above the fascia where no critical structures lie. I used no cautery in the 26 implants that I did. The blunt dissection tool is placed to make the pocket. My finger is a backstop. Normal saline flush. The electrical field is placed facing down. A fascial stitch is used to make sure your foreign body doesn't migrate towards the incision line, improving safety. A multi-layer closure is performed. It's nice that you can, while you're doing it, tell the patient about post-procedure expectations. It is kept dry for 2 weeks with a shower bag. That compression sock is utilized for 4 weeks, they're given 2 of them. So post-procedure, it's a very achievable post-op compliance, I found. It's truly set it and forget it after activation by a field clinical engineer, so perhaps offering seamless maintenance. The therapy is automatic with no patient involvement. The pivotal device has an average battery life of 3 years. Hopefully the next generation will be 5. The electrical paradigm is, as explained, initially going off every 3 days and then every 4th day. Subjective and objective assessments made from 4 to 48 weeks, including monitoring for any safety issues. These were your typical OAB patients. They were highly bothered by their symptoms and had impaired quality of life. They tended to void over 10 times a day and have over 4 UUI incidents a day. In regards to disposition, 97% of patients that enrolled were implanted. There is no trial procedure or screen that excluded getting an eCoin implant. There are no special operators. 12 out of 15 of the physicians were absolutely new to the procedure. In regards to results, 71% of intent to treat population are at least 50% or better. 1 in 4 are dry. Average drop in UUI is minus 62%. The median is minus 70%, indicating that those responding are responding very well. This is a slow onset of action therapy, but the drop of minus 2.7 UUI is sustained from week 8 out to 6 months. Patients had their bothersome symptoms drop significantly and a meaningful improvement in quality of life. 77% of patients were better or above, indicating subjective and objective measurements are equaling each other. In regards to safety, 12% of patients had mild to moderate wound issues such as cellulitis or poor granulation of the incision. The leg does not have the same blood supply that we're used to in the buttocks, so they do need careful wound care post-operatively. 2.3% were explanted for infection, well within the norm for neuromodulation device. The device can track up the nerve, not affecting efficacy, and micro movements anterior and posterior until encapsulation occurs. This is one of my patients immediately after the procedure and then at 8 weeks. So in summary, 71% of intent to treat population are 50% or better, 1 in 4 are dry, and safety is certainly within the norm for neuromodulation devices. So potentially, we have a radically novel form factor that might not intimidate patients as much, that I hope in the future will become a dramatically appealing choice, and providers can consistently deliver neuromodulation using minimal resources, which is what healthcare needs. Excellent efficacy is achieved without a trial or screen. The therapy is automatic and sustained for years. Potentially, we can better penetrate this vastly undertreated population not well managed and avoid current burdensome and/or undesirable options, often compromised by poor adherence. Thank you.
Questions from the audience?
Did you or are you going to collect any patient-reported outcome measures?
In regards to
Efficacy. Yeah. This is all voiding diary? Or?
3-day voiding diary, and then we'll back up at PGII and OABQ. I'm sorry, that was listed in a slide. Yes.
Dr. Peters?
Very nice study. Maybe I missed it. The time to efficacy was, because I know you said it was prolonged, but I don't think I saw
So
it.
in the
Is it similar to PTNS? I mean,
Exactly.
okay. And because you're doing it twice a week, I'm just wondering if you're getting people better in 6 weeks instead of 12 weeks.
That's a great question. Still learning. I would love to talk after about an even more, we should talk, but yes, in my opinion, you're getting it sooner.
Okay, and then on your PGII or the moderately or markedly better, the two high ends, you know, when you look at the PTNS data, they were higher than that when you look at the sham, because there's no placebo in this. So when you look at So I guess my question to you would be, why don't you think you have pushing 75 or 80% of people saying they're moderately or markedly better? Because that's kind of what you would see in an open label PTNS trial. And does that,
Great
how does that
question.
jive with your incontinence? So.
I mean, I think it lines up with the dry rate of 1 in 4, where certainly those dry patients are going to be in those top 2 categories. And then I always go back to, I think once anyone has an incision on their body and has an implant placed, their expectations are really high. So, but should be studied more.
Thank you.